50 incidence rate increase tell us? The sharp increase in colorectal cancer incidence rate at age 50 is consistent with colorectal cancers detected during screening. Greater than 90% of these colorectal cancers are invasive, meaning beyond in situ stage, and they could, most, or at least many, could be prevented or detected in an earlier stage if earlier screening occurred. So that is really the key points of this study. So now I'm going to shift gears and I'm going to talk about hereditary colorectal cancer. So we suspect that, the reason I put this picture of the iceberg up here is because we think that there's a large burden of genetic colorectal cancer out there, but because genetic testing rates are suboptimal, we're just not finding these patients. So that's actually an important concept. So some of the syndromes you may see out there, the most common would be Lynch syndrome. This was previously referred to as hereditary non-polyposis colorectal cancer, but that terminology is not really used anymore. Then there's something called FAP, familial adenomatous polyposis, and then related to that is attenuated FAP. And then finally, we have MUTYH polyposis syndrome, which in contrast to these are all autosomal dominant. This one's autosomal recessive. So there are other syndromes out there that can be associated with colorectal cancer, but these are really the most common ones that you'll see. So you should suspect a syndrome if you see colorectal cancer or polyps at a young age, a large number of polyps, distinctive extracolonic cancers, and a strong family history. When I say distinctive extracolonic cancers, for example, in Lynch syndrome, the second most common cancer is uterine cancer. And in fact, you could have people with Lynch syndrome that develop uterine cancer and they may not even have a family history or personal history of colorectal cancer. So you have to be, you need to be familiar with these syndromes because you'll miss them if you don't know all the different types of cancers involved in the syndromes. So I do want to focus on Lynch syndrome because this is the most common hereditary colorectal cancer syndrome. And in fact, it accounts for 3 to 5% of all colorectal cancer cases. So this is not just some obscure syndrome. We're talking about thousands of people every year with colorectal cancer that will be diagnosed with Lynch syndrome. And in fact, we think it's about 7,000 cases per year of colorectal cancer per year are probably Lynch related. In early onset colorectal cancer, so if you're under age 50 and you have colorectal cancer, about 1 in 5 people will have Lynch syndrome. And there are about 1 in 279 people in the United States that are mutation carriers, which accounts to about 1 million people walking around with this in the United States, but unfortunately most of them are completely unaware that they're carriers because no one took a detailed family history or they didn't undergo genetic testing. So this is a major ticking time bomb. This syndrome is autosomal dominant with up to an 80% lifetime risk of colorectal cancer. And because it's a non-polyposis syndrome, you're often not going to see many polyps. In fact, you may see no polyps. You may just develop colorectal cancer. And as I mentioned, the uterus is the most common site outside of the colon. Okay. So in terms of pathogenesis, so there are defects in mismatch repair genes with associated defective mismatch repair proteins. And these proteins, when they're functioning properly, normally correct errors in DNA replication. But if you have a mutation in the gene in a dysfunctional protein, it can't correct the errors, and then you get these high rates of microsatellite instability, which leads to tumor formation. And there are 4 genes that are involved in this syndrome. And again, this is not like some random thing on USMLE step 1 or something like that, where they test you for these obscure facts. These 4 genes are very commonly tested for, and I think everybody needs to know about them. So there's MLH1, MSH2, MSH6, and PMS2. So if you have a mutation in one of these genes, you're going to have a deficient corresponding mismatch repair protein. So for example, if you have an MLH1 mutant, you're going to be missing or you're going to have a dysfunctional MLH1 protein. This is just from the National Comprehensive Cancer Network guidelines, which I encourage everybody to read. They're free. And you can see this shows what the risks of these various cancers are by age 70 in the general population. And then if you have one of these 2 Lynch mutations, what the risk would be. So colon cancer, you have about a 5% lifetime risk, just in general, of developing colorectal cancer. But if you are a Lynch carrier, your risk could be about up to 82% lifetime risk. And for uterine cancer, the general population risk is about 3%. but it could be up to 60% if you're a Lynch carrier. And the list kind of goes on and on. So there's like stomach cancer, ovarian cancer, hepatobiliary, urinary tract, small bowel, CNS, pancreas. So this spans multiple specialties. This is not like a GI issue alone, right? This spans primary care, surgery, oncology, neurology, neurosurgery, GYN. So these cancers can be seen in multiple patients that will present to multiple different types of clinics. So everyone really needs to be aware of these. There's some newer associations that came out in 2018. So in fact, prostate cancer is now felt to be linked to Lynch syndrome, and breast cancer is felt to be linked to Lynch syndrome as well, specifically to MSH6 and PMS2 mutations. So Lynch syndrome testing, for an overview, really there are two ways to do this. The first approach is to start with testing of the tumor tissue. So if we do a colonoscopy and we find a colorectal cancer, generally we're going to ask for microsatellite instability testing on the tumor tissue or immunohistochemistry testing of those mismatch repair proteins that I was talking about. So you could do one or the other. And then if this is abnormal, you're going to proceed to germline testing, which means you draw the patient's blood and sequence the DNA. On the other hand, if you have a patient that doesn't have cancer but has a strong family history, then you're going to have to do germline testing because there's no tumor in that patient to test. But generally, if somebody has colorectal cancer or even some other types of cancers, you could do tumor tissue testing as a first step and then germline testing afterwards if this is abnormal. So there's a new guideline, it's a national guideline that calls for universal testing. So this states that MSI and or IHC testing should be done on all colorectal cancer patients regardless of age. So I don't know if people remember like the Bethesda criteria, the Amsterdam criteria. These are like these kind of dinosaur criteria from like 20 years ago that basically said you have to have all these people in your family with colon cancer and the 3-2-1 rule, blah, blah. You could throw that all out the window because although that's really important, there's so many patients and family members that do not meet these criteria. So if you relied, for example, on the Amsterdam criteria, you would miss pretty much everybody with Lynch syndrome. So now the guideline is if you have colorectal cancer, you need to do this tumor testing. And I'm not sure if you have a tumor testing protocol in your hospital here, but there needs to be one so that every single person with colorectal cancer gets MSI or IHC testing according to these national guidelines. And then also we need to focus on patients who may have a family history of cancer, but they themselves do not have cancer. So if you're in a primary care clinic, and people are, giving you a concerning family history, they may meet criteria for genetic testing, and it's really important to actually ask about a family history. So to talk a little bit more about that family history gathering, for example, in the primary care setting or any clinic, really, GI clinic, etc., there's something called a PREM score. This is a prediction model for gene mutations. This is a very easy website to use that's based at Harvard. And you can just Google it. I just Google it. I just put it in PREM score. And then the first thing that comes up is this thing. And you pull it up. And it takes literally like 35 seconds to fill out. Of course, you need to know the family history information. So you have to ask the patient what the family history is. But you just plug in these numbers. And it pops out a percentage chance that this person would have a Lynch syndrome mutation if you were to do germline testing. And if so, this is kind of what it looks like. So you pull up this website. This is the first thing it asks you. Male, female. This is the patient. Male, female, current age. Has the patient had colorectal cancer? Yes, no. If so, how many colorectal cancers? And it starts asking about first-degree relatives. And then boom, you hit return, and then it calculates this risk. And generally, they say that if the predicted probability of having a Lynch mutation after you do this calculation is 2.5% or higher, you got to send that patient for genetic counseling or order germline testing. So this is a key thing. I do want to shift gears. We're kind of winding down here. I don't think I have too many slides. I want to leave time for questions if people have any. But I want to talk about some of the additional research that we've been doing at Tulane and LSU and utilizing the Louisiana Tumor Registry that focuses really on Lynch syndrome. So this was a paper we published in the American Journal of Gastroenterology in 2015, and it's titled Population-Based Lynch Syndrome Screening by MSI Testing in Patients 50 and Under, Prevalence, Testing Determinants, and Result Availability Prior to Colonic Surgery. So this paper really demonstrated the underutilization of tumor testing for MSI and or IHC in young patients. So as I just mentioned before, if you're 50 or under and you have colorectal cancer, you have about a 1 in 5 chance of having Lynch syndrome. And because it's autosomal dominant, that means that half your family members can have Lynch syndrome. And you can see from the statistics I showed you that you can have each of those people that are carrying a Lynch mutation can have an up to 80% lifetime risk of colorectal cancer, a 60% risk of uterine cancer, risk of ovarian cancer, breast cancer, etc. So obviously we want to identify these patients, right? But unfortunately what we showed is that the testing rates are dismal. So we utilized CDC comparative effectiveness research data, which is really just a fancy term for detailed registry information that Louisiana was given funding for in 2011. So the CDC funded the Louisiana Tumor Registry to look specifically to see if MSI and IHC testing was being done in all the patients with colorectal cancer in Louisiana. So we decided to look at people 50 and under, because those are the highest risk people, to see if the testing was being done. It was actually a pretty simple study. And what we found out is that Lynch syndrome, the screening rate with MSI and or IHC was only 23%. So that is really, really, really low, right? It needs to be 100%. And as I mentioned, if you don't do it, you will miss a lot of people, and importantly, a lot of family members with one of these cancer-causing mutations. And when we actually did a more detailed analysis, we found that the rates of testing were exceedingly low in the public hospital system. So I guess that would kind of be like the charity hospital system. 6.5%. This probably means like 1 person a year is tested for this, even though they probably see lots of people with colorectal cancer under age 50. But even in these other hospitals, like community hospital cancer programs, it's a CHCP, you would think that if it's a cancer program, they would be attuned to this. And you can see that even in the CHCPs, the results were really low. I mean, it was like 17%. If you're a comprehensive cancer program, the testing was 40%, but that's still, it's not good. And then if you looked at urban versus rural, you can see that in rural areas, the testing was only 12.3% versus 26% in urban, so it shows the disparity. Interestingly, we looked at different regions in Louisiana, and region 2 is the Baton Rouge area, and their testing rates were higher than everywhere else. So we're not really sure why that's the case. There's the Pennington Biomedical Research Center there, which focuses on genomics. I know they have several genetics counselors in that region, so maybe that's why, but I'm not sure. Another key thing that I want to get across to everybody is the timing of MSI and IHC testing. So preoperative testing on colonoscopy biopsy specimens as opposed to surgical resection specimens is really the way to go. Preoperative MSI testing guides germline testing and extent of colonic resection during surgery. And the reason that this is important is because metachronous colorectal cancer rates in someone who undergoes a segmental resection, so metachronous means at a future time, so synchronous colorectal cancer means 2 colorectal cancers in the colon at the exact same time. Metachronous means colorectal cancer at day 1, and then like a few years later, whenever you have a second metachronous cancer. So if you do a segmental resection on somebody with Lynch syndrome, they have a very high rate of developing a second cancer years down the line. So it can be 16% at 10 years, 41% at 20 years, and 62% at 30 years. So really, the ideal thing is to figure out if somebody has Lynch syndrome before they go to the operating room, so that you can at least have a discussion with them about taking more colon out. Now, I'm not saying that every single patient or every surgeon is gonna, after they discuss the risk benefits of total colectomy with a patient, not every patient is gonna wanna go through that. But they should at least have the information to know what their risk of developing a second cancer is. But if you don't have this MSI or IHC testing available before the patient goes to the operating room, then that's a missed opportunity to have this risk-benefit discussion with the patients. And so if you're not doing this MSI and IHC testing on the colonoscopy biopsy specimen, but instead if you're doing it on the surgical resection specimen, that's a problem. If you do it on the surgical resection specimen, the test results are going to come back after the patient has already had a segmental resection. And then it's going to come back like 5 days later and be like, oh wow, I didn't, the IHC's abnormal, it suggests Lymph syndrome, I have to do germline testing. And then 2 or 3 weeks later, the patient's in your office and you're having a conversation with them that, I left most of the colon in, and you have a 60% chance of getting another colon cancer within the next 30 years, or 20% within the next 10 years. So this is an important concept. And when we published this paper in the Red Journal, we actually were able to, the CDC comparative effectiveness data, research data we had, was so granular that we were actually able to tell whether the testing was done on a colonoscopy biopsy specimen or a surgical resection specimen. And what we ended up finding out is that MSI and IHC results were available preoperatively in only 16.9% of cases. So that means the results were almost always coming back after the patient had surgery. And that was for one of 2 reasons. Number one, it may have actually been done on the colonoscopy biopsy specimen, but the patient may have went to the OR the next day and there was no time to process the sample. Or the patient may have just had a surgical resection and somebody ordered it on the surgical resection specimen. So that's a key finding, we thought. So with all this talk of like these low rates of testing and the timing of testing not being optimal, we decided to do a national survey of gastroenterologists through the American College of Gastroenterology mailing list to try and find out why are these MSI and IHC testing rates so low? What is driving this behavior? So we wanted to use this Louisiana data that we obtained and kind of use that as a jumping off point to figure out what's going on nationally. So we published this 2 years ago, and the main goals of the study were, number one, what are the barriers to ordering this testing? What are barriers to preoperative result availability? And we had about 6,000 confirmed questionnaire recipients by email. 509 took the survey, so that's a 9% response rate. That is not ideal, right? And we were disappointed with that. But there's some studies showing that if you are surveying physicians, even if you get a low response rate, just due to general how homogeneous knowledge could be, like it may actually be representative. But it wasn't exactly what we were hoping for, but it's also kind of a topic that people are not that familiar with. So we weren't surprised to see that degree of a low response rate. But what we found was that for barriers to test ordering, these were kind of the most common things. So people, for some reason, thought MSI and IHC testing was prohibitively expensive. A lot of people were unfamiliar interpreting the results, so they didn't want to send it off because they didn't want to get a result back and not know how to act on it. And then the third thing is that a lot of people said that they were concerned that they didn't have genetic counseling to help deal with an abnormal test. And a lot of these barriers clustered in non-academic settings and rural settings, particularly for cost and genetic counseling barriers. This was another interesting question that we asked, is we asked all of these GI providers, who do you think is responsible for ordering this testing? Is it you as the gastroenterologist? Is it the surgeon? Is it an oncologist? Is it a genetic counselor? Is it the pathologist? And it was like all over the board. The most common response was that the pathologist should be responsible for it. Then the second most common was the GI doctor, and then some people thought the surgeon should be responsible. Obviously that's not a good option because the surgeon is already going to do the operation, right? You want to know what's going on beforehand. Same like medical oncologists, they thought maybe genetic counselor. So we term this diffusion of responsibility. So it's like a hot potato. So everybody thinks somebody else should be doing the testing. And those other people, they think you should be doing the testing. So what does that mean? Nobody does the testing. So that's probably why these rates are really low. And in terms of preoperative result availability, only 46% of the respondents to the survey felt that MSI and IHC should always be performed on colonoscopy biopsy specimens. So that's another issue. I guess people are just not aware of the fact that these test results could affect how you manage the patient with regards to operative extent. So potential solutions to this is probably the best solution. You should have a reflex automatic MSI or IHC testing protocol in your hospital so that there's no specific provider responsible for ordering this stuff. It should just get done automatically. Now, obviously, that's going to lead to results that need to be dealt with, right? So even if you have reflex testing in place, you still need somebody designated and with expertise to be able to act on the results. So that's important. And then, we really need to maximize genomics education and training and with ongoing CME because this stuff is becoming more and more commonly utilized. And if we don't know how to deal with these results or understand what the implications of a family history are, it's going to put patients at risk. And then we really need to target underserved populations in which these barriers seem to be more pronounced. So to conclude the talk, I think it's only 12:44, so that's good. As you can see, the colorectal cancer screening guidelines are in flux. There's a rising incidence of early onset colorectal cancer, and the American Cancer Society states that screening should begin at age 45. I showed you the publication that we just had last week showing this spike in colorectal cancer from 49 to 50, which we're hoping when they redo the guidelines that they can kind of incorporate that data in their decision making, because we think the risk in people of 45 to 49 is much higher than what SEER cancer statistics reflect. And then obviously Louisiana has a very high colorectal cancer incidence and mortality burden, but our screening rates are not optimal, so we need to do a better job of that. Hereditary colorectal cancer syndromes are associated with very high cancer rates and risk to family members, and our research shows we need to do a much better job nationally to identify these hereditary syndromes. So back to those clinical questions. A 68-year-old male presents with rectal bleeding and is found to have a asymmetrical mass on colonoscopy showing adenocarcinoma. No family history of cancer. What do you recommend? A, recommend first-degree relatives have colonoscopy at age 40 and every 5 years afterwards. This is actually incorrect because of the universal testing thing that I talked about, right? Universal testing says that everybody has to be tested for lymph syndrome with colorectal cancer. So it's not going to be B, right? You're not going to be like, oh, the person's 68 and they have no family history. There's no risk there. So that's wrong. So then there's C or D. Recommend MSI testing on colonoscopy or recommend MSI testing on surgical resection. I think we kind of went through this. You want to try and know the answer to the question before the patient goes to the OR. Clinical question 2. Which of the following best describes the epidemiology of colorectal cancer in recent decades for patients 55 years and older, like our patient who's 68? Kind of just jump right to the answer. Rates are going down in people 55 years and older, but they're going up in people that are under age 55. Clinical question 3. Our 68-year-old patient ends up having an MSI high tumor and has germline testing